safely lifting, moving, and positioning patients. The theory learning objectives include the following. Examine the nurse's role related to nutritional therapy and special dietary needs. Contrast a full liquid diet with a clear liquid diet. Distinguish the different dietary modification levels: pureed, mechanically altered, advanced, and regular. Describe health issues related to nutrition. List disease processes that may benefit from nutritional therapy. Debate the rationales for assisted feedings and tube feedings. Diagram the steps for the procedure to insert, irrigate, and remove a nasogastric tube. Discuss the steps to the procedure for managing a tube feeding. Identify the medical rationale and nursing care for a patient receiving peripheral parenteral nutrition, PPN, and total parenteral nutrition, TPN. Relate the possible complications associated with modified diets, tube feedings, PPN, and TPN. The clinical practice learning objectives include: propose therapeutic communication to assist a patient who requires a special diet. Review a patient education plan for nutritional therapy. Demonstrate insertion, irrigation, and removal of a nasogastric tube. Demonstrate feeding a patient through a nasogastric tube or percutaneous endoscopic gastrostomy, PEG tube. Employ your facility's policies, procedures, and protocols for nutrition-related problems and complications with tube feedings. Nutritional therapy overview. When we think about nutritional therapy, the main purpose is to use food and nutrients as part of a patient's overall treatment plan. The first goal is to treat and manage disease. For example, patients with diabetes may require a carbohydrate-controlled diet to help regulate blood sugar levels. Similarly, patients with hypertension may need to limit sodium intake to help manage their blood pressure. Nutrition is not just about eating. It is a therapeutic tool that works alongside medications and other treatments. The second goal is to prevent complications and restore health. Many diseases can worsen if the patient's nutritional needs are not met. For instance, patients recovering from surgery need adequate protein to heal wounds. If they don't get it, recovery is delayed and complications like infections can develop. This is why providers prescribe specific diets on the physician's order sheet. It ensures the patient's nutrition matches their medical needs. To make sure these goals are met, patients undergo a thorough diet assessment. This assessment helps the healthcare team identify calorie, protein, and micronutrient requirements. It also helps uncover barriers such as difficulty chewing, swallowing, or digesting certain foods. Some patients may also need assistance with feeding, for example, individuals with weakness from a stroke or those with advanced dementia. In these cases, LPNs play a vital role in supporting safe and adequate food intake. Finally, it's important to recognize that energy needs diminish with age. As metabolism slows and activity decreases, older adults generally require fewer calories, but they still need nutrient-dense foods to maintain strength and prevent malnutrition. Some patients, however, are placed on unrestricted diets that closely resemble what they would eat at home, especially if their medical condition allows. This helps promote comfort, independence, and quality of life. Some patients are unable to feed themselves safely or effectively, and as LPNs, you need to recognize who requires feeding assistance. Patients with paralysis of the arms lack the motor ability to bring food to their mouth, so they rely on caregivers for meals. Those with visual impairments may be physically capable of feeding themselves, but they may struggle to locate food on the tray or cut food safely. In these cases, nurses can assist by orienting food using the clock method or providing adaptive utensils. Patients with intravenous lines in their hands may experience pain or restricted mobility, making self-feeding uncomfortable or unsafe. Similarly, severely impaired or weak patients, such as those recovering from surgery or dealing with progressive illnesses, may not have the strength or coordination to manage meals. Finally, confused patients, such as those with dementia or delirium, may forget to eat, be unable to use utensils, or even put themselves at risk of aspiration. In these cases, the nurse must monitor carefully and provide direct assistance as needed. Feeding can sometimes be delegated to a nursing assistant or family member, but as the nurse, you are still responsible for assessing tolerance, monitoring intake, and ensuring safety. Documentation is also critical. Tracking how much the patient eats, any signs of difficulty swallowing, and whether there are changes in weight or hydration status. Proper feeding support not only maintains nutrition but also preserves dignity and comfort for the patient. When caring for a post-operative patient, nutrition plays a critical role in healing and recovery. Before surgery, patients should be well nourished so their bodies have the energy and protein reserves needed for wound healing and to fight off infection. Most patients are placed on NPO status, nothing by mouth, for 6 to 8 hours before surgery. This is done to reduce the risk of vomiting and aspiration while under anesthesia. After surgery, patients are slowly reintroduced to food and fluids. The first step is usually a clear liquid diet. This is easy to digest and helps assess whether the gastrointestinal system is functioning. If tolerated, the patient may advance to a full liquid diet, which provides more nutrients and variety but is still gentle on the stomach. From there, they may move to a soft diet before returning to a general or regular diet, depending on their condition and tolerance. Nurses must carefully monitor tolerance to diet progression. Key assessments include checking bowel sounds with auscultation, ensuring swallowing reflexes are intact, and monitoring for signs of nausea, vomiting, abdominal discomfort, or distension. The absence of bowel sounds is a warning sign that the intestines are not ready for food, and feeding too early could result in complications such as ileus. When advancing diets, the goal is to provide low-residue, easily digested foods at first, gradually building up to more complex meals. Warm or cold liquids should be offered instead of tepid ones, as these are better tolerated. In some cases, patients are given ice chips before the first meal to test swallowing and comfort. Overall, the nurse plays a central role in promoting safe diet advancement and preventing complications such as aspiration, nausea, or delayed healing. When we discuss liquid diets, it's important to recognize that they serve specific purposes in patient care, especially after surgery, during illness, or when the digestive system needs rest. Liquid diets are classified into clear liquids and full liquids, each with a different purpose and nutritional value. Clear liquid diets are made up of transparent, easily digestible fluids that leave little residue in the gastrointestinal tract. Examples include apple, grape, and cranberry juices, strained fruit juices, vegetable broth, carbonated water, clear fruit drinks, gelatin, popsicles, tea, coffee, and clear broth. These diets are typically used for short periods. For example, immediately after surgery, during acute gastrointestinal illness, or before diagnostic tests. They help maintain hydration and provide a small amount of energy, but they are not nutritionally complete. Patients cannot remain on clear liquids for long without risking malnutrition. Full liquid diets, on the other hand, contain all items from the clear liquid diet plus foods that are liquid at room temperature. These include milk and milk-based beverages, yogurt, eggnog, puddings, custards, ice cream, sherbet, pureed meats and vegetables and cream soups, strained fruit and vegetable juices, sweetened plain gelatin, refined cooked cereals, blended gruel, and butter or cream. Full liquids provide more calories, protein, and fat than clear liquids, and they can be used longer term when a patient is unable to tolerate solid foods. In some cases, a full liquid diet may be modified with supplements to meet ongoing nutritional needs. As nurses, you must remember that clear liquids do not meet nutritional requirements, but full liquids can sustain patients longer if properly balanced. When advancing diets, always monitor for tolerance, including nausea, vomiting, abdominal pain, or diarrhea. You should also be aware of patient preferences, cultural food practices, and any food allergies. Anorexia nervosa is a serious mental health disorder in which individuals have an intense fear of gaining weight and a distorted body image. Patients refuse to maintain a normal body weight, even when they are extremely underweight. Despite being malnourished, they may still restrict food intake or exercise excessively because of their overwhelming fear of becoming obese. If untreated, anorexia nervosa can be life-threatening. Severe malnutrition affects every body system. Cardiac complications, electrolyte imbalances, osteoporosis, infertility, and organ failure are possible outcomes. Mortality is high without intervention, making early recognition and treatment critical. This disorder occurs most often in teenage girls and young women, though it can also affect boys and men. Patients tend to avoid high-calorie foods and may exercise compulsively to burn calories. In severe cases, hospitalization is required. Treatments may include tube feeding or total parenteral nutrition, TPN, to correct malnutrition and stabilize the patient. Treatment requires a multidisciplinary approach. This includes the physician, nurse, dietitian, mental health professionals, the patient, and their family. As LPNs, you will often be on the front line, monitoring the patient's intake, encouraging healthy food choices, and providing emotional support. Treatment involves both nutritional intervention to restore weight and address deficiencies, and counseling to work through the underlying psychological issues. Recovery is often long-term and relapse is common, so consistent follow-up care and family involvement are essential. Bulimia nervosa is an eating disorder characterized by episodes of binge eating, followed by behaviors meant to prevent weight gain. These behaviors may include purging through self-induced vomiting, misuse of laxatives or diuretics, prolonged fasting, or excessive exercise. Unlike anorexia nervosa, patients with bulimia usually maintain a weight that is close to normal, but their eating patterns and compensatory behaviors cause serious health consequences. Patients with bulimia are typically aware of their behavior and often feel a deep sense of guilt, shame, or embarrassment. This self-awareness can sometimes make treatment more approachable, but it also increases the risk of depression, anxiety, and self-destructive behaviors. The disorder most often affects young adults, especially women, although it can occur in men as well. Complications include electrolyte imbalances that may lead to cardiac arrhythmias, dehydration, gastrointestinal damage such as esophageal tears or gastric rupture, and dental erosion caused by repeated vomiting. These complications highlight why early recognition and intervention are critical. Treatment is both nutritional and psychological. Nutritional counseling helps patients reestablish healthy eating patterns, while psychological therapy, such as cognitive behavioral therapy, addresses the underlying thought distortions and emotional triggers. Nurses play a key role in monitoring for physical complications, supporting safe eating behaviors, and providing emotional support. Collaboration with the healthcare team, including physicians, dietitians, and mental health professionals, is essential to promote recovery. Obesity is not simply being overweight. It is defined as an excessive accumulation of body fat that places stress on vital organs and body systems. This condition is more than just a number on the scale. It involves complex interactions between genetics, lifestyle, environment, and physiology. In the United States, obesity rates continue to rise, with nearly 40% of adults classified as obese. It is now recognized as the second leading cause of preventable death, contributing to millions of deaths each year. Obesity is linked to many serious health problems, including cardiovascular disease, stroke, type 2 diabetes, hypertension, kidney disease, arthritis, certain cancers, and emotional disorders such as depression and anxiety. These comorbidities make obesity not only a public health concern, but also a major factor in patient care. The causes of obesity are multifactorial. Genetics can predispose someone to obesity, but environmental factors and lifestyle habits such as overeating, lack of physical activity, and poor nutrition knowledge are significant contributors. Age, body physiology, and even gender can influence the risk. Importantly, many patients face barriers such as food insecurity, cultural habits, or limited access to healthy food and exercise opportunities. The primary goal of obesity treatment is not just weight loss, but also improving overall health and quality of life. For lasting improvement, patients must burn more calories than they consume, which requires dietary modification and increased physical activity. Interventions may include nutritional counseling, behavior therapy, support groups, and in some cases, medications. For patients with severe or extreme obesity, bariatric surgery may be considered. Surgical interventions such as gastric bypass or sleeve gastrectomy are often the most effective at producing long-term weight loss, but they are also complicated and high-risk procedures requiring lifelong lifestyle adjustments and follow-up care. As LPNs, your role includes patient education, emotional support, monitoring for complications, and encouraging adherence to treatment plans. Psychological support and counseling are equally important since obesity is often tied to self-esteem and emotional well-being. Nutrition during pregnancy is one of the most important factors influencing both maternal health and fetal development. A woman's nutritional status before and during pregnancy affects outcomes such as growth of the fetus, risk of complications, and the mother's ability to recover after delivery. Poor nutrition can increase the risk of low birth weight, preterm birth, and developmental problems. Weight gain is carefully monitored during pregnancy. In the first trimester, women should gain approximately 2 to 4 pounds total. During the second and third trimesters, healthy weight gain is about 1 pound per week. These guidelines help ensure that the fetus receives adequate nutrition without placing unnecessary strain on the mother. Calorie intake recommendations reflect this. No extra calories are needed during the first trimester, but by the second and third trimesters, an additional 300 calories per day is recommended. However, several factors can influence a pregnant woman's nutritional state. These include her pre-pregnancy health status, nausea and vomiting in early pregnancy, changes in appetite, which may be both emotional and physical, and access to foods with proper nutritional value. Morning sickness, food aversions, and cravings are common, but they should not interfere with maintaining a balanced intake of protein, vitamins, and minerals. For LPNs, it's important to understand that nutritional guidance for pregnant patients must be individualized. Nurses should monitor weight gain trends, assess dietary intake, encourage prenatal vitamins, especially folic acid, to prevent neural tube defects, and provide support for managing nausea or poor appetite. Reinforcing the importance of small, frequent meals and adequate hydration can help mothers maintain both comfort and proper nutrition. Substance use, including alcohol, smoking, and other addictive behaviors, often leads to nutritional problems. These individuals may not prioritize healthy eating, resulting in poor dietary intake. Substance use can interfere with food intake in two major ways. First, by decreasing appetite, and second, by decreasing financial resources available for purchasing nutritious food. Many people struggling with substance use prioritize the substance over food, which worsens malnutrition. In addition, substance use can cause impaired nutrient absorption. For example, chronic alcohol use is strongly associated with thiamine, vitamin B1 deficiency. Thiamine deficiency can cause Wernicke's encephalopathy, a neurological disorder with symptoms such as confusion, ataxia, and vision changes. Over time, continued alcohol abuse can also result in liver damage, leading to cirrhosis, ascites, jaundice, and impaired ability of the liver to metabolize nutrients. Smoking and drug use also increase oxidative stress in the body, further depleting vitamins and minerals. As LPNs, it is important to assess patients with a history of substance use for signs of nutritional deficits and organ damage. Nursing interventions include monitoring weight, encouraging nutrient-dense meals, and educating patients about healthier food choices. Collaboration with dietitians, physicians, and substance abuse counselors is essential. Since relapse is common, emotional support and referral to support groups are also a crucial part of care. Patients with a history of substance abuse are at high risk for nutritional problems, which makes dietary counseling an important part of their treatment plan. Substance abuse often leads to dehydration, electrolyte imbalances, and vitamin or mineral deficiencies. For this reason, treatment may include fluid and electrolyte replacement to restore balance and support normal organ function. Vitamin and mineral supplementation is especially important with a focus on thiamine, vitamin B1. Chronic alcohol abuse depletes thiamine stores, leading to neurological complications such as Wernicke-Korsakoff syndrome. Nurses play a vital role in recognizing early signs of these deficiencies and ensuring supplementation is provided. Dietary adjustments are also key. Patients recovering from substance abuse often require a high-calorie, high-carbohydrate diet to rebuild energy stores and correct malnutrition caused by prolonged poor intake. In cases where liver function is impaired from alcohol-related damage, fat intake may need to be restricted to reduce stress on the liver. As LPNs, you are responsible for monitoring nutritional status, documenting progress, and reinforcing dietary recommendations. Nurses provide education, encourage compliance, and support lifestyle changes while collaborating with dietitians, physicians, and substance abuse counselors. This teamwork helps patients restore their nutritional health and supports their overall recovery process. Cardiovascular disease is a broad category that includes conditions such as hypertension, myocardial infarction, heart attack, congestive heart failure, and diseases of the blood vessels. A major underlying factor in many of these conditions is atherosclerosis, which is the buildup of fatty plaques inside artery walls. These plaques narrow the arteries, reduce blood flow, and increase the risk of clot formation, which can cause heart attacks or strokes. Because of this, nutrition therapy focuses on reducing fat and sodium intake. Lowering saturated fats and trans fats helps reduce plaque buildup, while limiting sodium helps lower blood pressure and decreases strain on the heart. Patients should understand that sodium is present in many foods naturally, not just in added salt. Just 1 teaspoon of salt contains about 2,300 milligrams of sodium, which is the upper daily limit recommended for adults. Another important factor is cholesterol. There are 3 main types: high-density lipoprotein, HDL, known as good cholesterol, because it helps remove cholesterol from the bloodstream. Low-density lipoprotein, LDL, often called bad cholesterol, which contributes to plaque buildup. Very low-density lipoprotein, VLDL, which carries triglycerides and also contributes to plaque formation. To lower cholesterol, patients should avoid foods high in saturated fats, such as red meat, eggs, and high-fat dairy products, and instead include foods that help lower cholesterol, such as vegetable oils, fish, poultry, and low-fat dairy products. One diet that is often recommended for heart health is the DASH diet, dietary approaches to stop hypertension. It emphasizes fruits, vegetables, whole grains, lean proteins, and low-fat dairy, while limiting sodium, red meat, sweets, and sugary drinks. The DASH diet is effective in lowering blood pressure and improving overall cardiovascular health. Diabetes mellitus is a chronic disorder of carbohydrate metabolism, where the body is unable to use glucose properly because of problems with insulin production or insulin resistance. There are two main types: type 1 diabetes, which is insulin-dependent and often begins in childhood or adolescence, and type 2 diabetes, which is more common, often develops in adulthood, and is linked to lifestyle and obesity. Certain populations, including African Americans and Hispanics, are at higher risk. Diet management is essential in controlling diabetes. The goal is to maintain blood glucose between 70 and 120 mg/dL. Patients should avoid eating large amounts of carbohydrates at one time to prevent spikes in blood sugar. Instead, meals should be balanced, typically containing 45-60% carbohydrates, 20-25% protein, and 20-25% fat, with an emphasis on complex carbohydrates such as whole grains, vegetables, and legumes. For overweight patients, calorie restriction is important to reduce insulin resistance. Diet planning must be individualized based on factors such as age, sex, weight, activity level, cultural background, food preferences, and overall health status. Patients should eat meals at consistent intervals to match food intake with insulin or medication timing. Too much food can cause hyperglycemia and, in type 1, risk of ketoacidosis, while too little food can lead to hypoglycemia or insulin shock. Diabetic patients are at increased risk of long-term complications, including cardiovascular disease, hypertension, kidney disease, blindness, and stroke. Nurses play a key role in dietary counseling, teaching patients to plan balanced meals and reinforcing the importance of weight control, exercise, infection prevention, and skincare. By supporting patients in their daily self-care routines, nurses help them avoid serious complications and improve quality of life. Patients with HIV/AIDS often face significant nutritional challenges due to the impact of the virus on the immune system and the side effects of treatment. Common complications include severe diarrhea, profound weight loss, and muscle wasting. These symptoms are often the result of malabsorption, increased metabolic demands, and decreased appetite caused by nausea, vomiting, or infections. The goals of nutritional therapy in HIV/AIDS are to replace lost fluids and electrolytes, promote weight gain, restore muscle mass, and help maintain the immune system. Adequate nutrition can slow the progression of the disease, improve quality of life, and reduce the risk of opportunistic infections. In some cases, when oral intake is not sufficient, tube feedings or total parenteral nutrition, TPN, may be required. Loss of appetite is common, so patients benefit from small, frequent, nutrient-dense meals that are easier to tolerate. Protein-rich foods help rebuild muscle, while fluids and electrolytes are essential to counteract the effects of diarrhea. Supplementation with vitamins and minerals may also support immune function. As LPNs, it is critical to assess for weight changes, hydration status, and appetite, and to encourage patients to eat foods they can tolerate while balancing nutritional needs. Nurses also provide education about safe food handling, since immunocompromised patients are more vulnerable to foodborne illnesses. By supporting nutrition, hydration, and overall health, nurses play a vital role in maintaining the patient's strength and delaying the onset of more advanced disease. Nasogastric and other enteral tubes. Nasogastric and enteral tubes are essential tools in patient care because they provide nutritional support, hydration, and medication delivery when patients cannot safely or adequately take food by mouth. These tubes are usually considered a temporary measure, but for some patients they are critical lifelines. As nurses, it is vital to treat these tubes with care and respect, because without them, patients may not be able to receive the nutrition they need for survival and healing. Before administering any feeding or medication through an NG or enteral tube, the placement of the tube must be checked to ensure that it is correctly positioned in the stomach or small intestine. This step prevents serious complications such as aspiration pneumonia. Tube patency, meaning that the tube is open and unclogged, is confirmed by irrigating with water or saline before and after feedings or medication administration. There are many reasons for using NG and enteral tubes. They may be placed in patients with dysphagia, such as after a stroke, or in those with conditions like inflammatory bowel disease who need nutritional supplementation. They are also used for gastric decompression before or after surgery, for obtaining gastric specimens for diagnostic testing, for gastric lavage and poisoning or overdose, and for the routine administration of medications and enteral feedings. As LPNs, your role involves monitoring the tube site for signs of irritation or infection, ensuring proper placement and patency, keeping accurate intake and output records, and supporting patient comfort. Reviewing the anatomy of the nasopharynx and upper GI tract will help you understand the insertion pathway and recognize potential complications. Always follow your facility's policies and procedures for insertion, verification, and care. PEG and jejunostomy tubes are placed when a patient requires long-term nutritional support and cannot safely take food orally. These tubes bypass the nose and esophagus, delivering nutrition directly into the stomach or small intestine. They are inserted surgically or endoscopically and are often used in patients who have had strokes, cancers of the head and neck, neurological disorders, or chronic swallowing difficulties. For safe nursing care, tube placement must be checked at the beginning of every shift and before giving any feeding or medication. This prevents complications such as aspiration or accidental administration into the wrong location. Nurses should also assess for signs of infection around the insertion site, leakage, or dislodgement. Another important step before feeding or giving medications is checking for gastric residual volume, which is the amount of fluid remaining in the stomach. High residuals may indicate delayed gastric emptying and increase the risk for aspiration. If residuals are above your facility's threshold, often 200 ml or more, you may need to hold the feeding and notify the provider. As LPNs, your role includes flushing the tube to maintain patency, monitoring the insertion site, accurately documenting intake and residuals, and supporting patients emotionally, since tube feeding can affect their sense of normalcy and dignity. Nasogastric tube insertion. When we talk about inserting a nasogastric tube, it's important to remember this is a provider-ordered procedure, meaning the nurse cannot insert the tube unless the provider writes an order. The NG tube has several important uses. It can be placed for decompression, which means removing air or fluid from the stomach, often after intestinal surgery to prevent distension and discomfort. It may also be used with suction when the patient is vomiting excessively or at risk of aspirating stomach contents due to decreased consciousness. In addition, NG tubes can be used for feeding, either connected to a pump for continuous delivery or left clamped for intermittent feedings. As an LPN, your role is to know why the tube is being inserted, to perform the skill safely, to monitor the patient closely for complications such as discomfort, aspiration, or tube displacement, and to document thoroughly. Documentation should always include the type and size of tube, insertion site, length inserted, patient tolerance, and any aspirated contents. This skill requires both technical ability and strong communication with the patient to minimize anxiety and maximize cooperation. Explain the procedure to ease anxiety. Patients are more cooperative when they understand what's happening. Screen for contraindications such as basilar skull fractures, facial or nasal trauma, esophageal strictures, severe coagulopathy, or recent upper gastrointestinal surgery. Inspect both nostrils for patency, obstructions, polyps, septal deviation, or injury. Ask about any history of nasal surgery or frequent nosebleeds. Check for intact gag and cough reflexes, which help protect the airway during insertion. If reflexes are impaired, extra caution and possible provider involvement are necessary. Assess vital signs, oxygen saturation, and respiratory status before insertion. Note any pre-existing difficulty breathing, swallowing, or coughing. Perform an abdominal assessment, inspection, auscultation, palpation to establish baseline findings and confirm the need for gastric decompression or feeding. Select the nostril that is most patent. Check nostrils for airflow and choose the more patent one. Elevate the head of the bed to use gravity to your advantage. Agree on a signal for the patient to stop you if the discomfort is too much. This gives them a sense of control. When inserting a nasogastric tube, measuring the correct length is critical to ensure the tube reaches the stomach and not the respiratory tract. If the tube is not measured correctly, it can result in underinsertion, where the tube doesn't reach the stomach, or malposition, where it may coil in the throat or enter the lungs, both of which are dangerous. The traditional NEX method measures from the nose to the earlobe and then down to the xiphoid process. This length is then marked with tape and used as the guide for insertion. However, studies have shown that the NEX method sometimes leaves the tube too short, risking placement in the esophagus. The Hansen method is considered more accurate. It involves marking the tube at 50 centimeters and then taking the midpoint between that mark and the NEX measurement. This ensures the tube is inserted slightly farther, reducing the risk of misplacement. Regardless of the method used, always mark the tube clearly with tape so you know your target insertion point. When inserting a nasogastric tube, always lubricate the tip with a water-soluble lubricant. Oil-based lubricants should never be used because they increase the risk of aspiration if the patient accidentally inhales the substance into the lungs. Choose the nostril with the best airflow, as this will make passage easier and reduce trauma. Insert the tube slowly using a gentle twisting motion. Never force the tube. If you meet strong resistance, withdraw slightly and attempt again in the other nostril. Forcing the tube risks causing tissue damage or bleeding. As the tube advances into the throat, encourage the patient to sip water through a straw and swallow. Swallowing activates the natural peristaltic reflex, which helps guide the tube down into the esophagus instead of the trachea. At this stage, instruct the patient to flex their head forward, which further directs the tube away from the airway and toward the stomach. Always monitor the patient closely for warning signs. If the patient begins coughing, turns cyanotic, or appears in respiratory distress, stop immediately. These are red flags that the tube may have entered the airway. Before using a nasogastric tube for suction, feeding, or medication administration, placement must be confirmed. The gold standard is an X-ray, which is often required for all new insertions to ensure the tube is properly in the stomach and not in the lungs or intestines. At the bedside, nurses may also use aspiration testing. Using a syringe, gently withdraw gastric fluid and test its pH. Gastric secretions are typically acidic, with a pH of 1 to 4. If the aspirate shows a pH above 6, this could suggest that the tube is in the intestines or, more dangerously, in the respiratory tract. In that case, do not use the tube and notify the provider. In addition to pH, observe the color and consistency of the aspirate. Gastric aspirate is usually grassy green, clear, or colorless. Intestinal aspirate tends to be bile-stained or yellow-brown, and respiratory aspirate is often tan, cloudy, or mucoid. These differences are important to recognize. Always remember that if placement cannot be confidently confirmed, the tube should never be used. Incorrect placement carries serious risks, including aspiration pneumonia or lack of effective feeding. Once the NG tube's placement has been confirmed, the next critical step is to secure the tube. Clean the bridge of the nose with alcohol or benzoin to help the tape adhere. You can use either the split tape method or a commercially designed NG tube holder. This prevents the tube from shifting or becoming dislodged, which can be uncomfortable and even dangerous for the patient. Always measure and document the external length of the tube from the nair to the tube tip. This serves as a baseline and allows you to quickly identify if the tube has migrated out of position during care. When connecting the tube, attach it to the prescribed suction or feeding equipment. For decompression, connect to low intermittent suction to prevent mucosal injury. For feedings, connect to the ordered feeding pump and ensure the prescribed rate is set. To prevent accidental pulling, create a loose loop with the tube, secure it with tape, and attach it to the patient's gown with a safety pin. This keeps the tubing from tugging at the patient's nose and helps reduce skin breakdown or accidental removal. After inserting and securing an NG tube, your focus shifts to post-procedure care and monitoring. The most important step is to assess for effectiveness. If the tube was placed for decompression, ensure that drainage is flowing properly into the suction canister and check that the patient's nausea or abdominal distension is being relieved. For feeding tubes, check residual gastric volume every 4 hours to make sure the stomach is emptying appropriately and that the patient is tolerating the feeding. High residuals may mean delayed gastric emptying, which increases the risk for aspiration. Always record these residual volumes and follow your facility's policy on whether to discard or return aspirated contents. Frequent oral and nasal care is essential because the tube can irritate the mucosa, leading to dryness, discomfort, or even skin breakdown. This step not only improves comfort but also decreases infection risk. Finally, always prioritize the patient's comfort and safety. Reassure them, monitor for pain, and intervene quickly if complications such as abdominal discomfort, nausea, or difficulty breathing occur. Accurate documentation is one of the most important responsibilities after NG tube insertion. Documentation ensures continuity of care and clear communication with the entire healthcare team. Always record the date and time of the procedure, along with the reason for insertion such as decompression, suction, or feeding. Include the tube type and size, insertion site, and the external length at the nares. This is critical for detecting migration during future checks. Placement verification must also be documented, including whether placement was confirmed by X-ray or by bedside methods, such as aspirate pH. Record the amount, color, and consistency of aspirated gastric contents. For example, gastric aspirates are often green or clear, with a pH of 1.4. Finally, describe the patient's tolerance and response. Did nausea improve? Was abdominal distension relieved? Did the patient vomit during insertion? These details provide valuable feedback for ongoing care and evaluation of tube effectiveness. Please check out the attached link to watch a video of NG tube insertion. NG tube irrigation. Nasogastric tubes must remain open and functional, which means we often irrigate them to ensure patency and prevent clogging. Irrigation may be ordered every few hours or once a day, depending on the patient's condition and provider's orders. The solutions most commonly used are normal saline or sterile water. Normal saline is isotonic, which helps avoid disrupting the patient's electrolyte balance. Always begin by verifying the provider's order for both the irrigation frequency and type of solution. This ensures you are following the prescribed plan of care. Next, assess the gastric secretions for color, amount, and consistency. These give you important baseline data. Assess bowel sounds carefully because they can indicate whether the GI tract is beginning to function normally again. Also, always ask about discomfort because this may point to complications like obstruction, irritation, or incorrect tube placement. Before irrigation, position your patient in semi-Fowlers, about 30 to 60 degrees. This upright position helps prevent reflux or aspiration. Always wash your hands thoroughly and put on gloves. Since gastric secretions are body fluids, gloves protect you and prevent contamination. Attach the syringe to the NG tube and instill the solution slowly. This helps clear the lumen of any mucus or blockages. After irrigation is complete, reconnect the tube to suction and restart the suction. This restores function, whether for decompression or gastric drainage. Always double-check that suction is functioning properly. After you finish, remove your gloves and wash your hands to prevent spreading microorganisms. Make sure your patient is comfortable and safe, adjusting their position as needed. Finally, document the irrigation. Always chart the type and amount of solution instilled and add that to the intake record since it counts toward fluid intake. Documentation provides continuity of care and ensures accurate fluid balance monitoring. As an example, you may document NG tube in left nostril irrigated with 30 ml normal saline per provider order. Tube placement verified prior to irrigation, aspirated 50 ml green gastric fluid, pH 2, irrigation instilled without resistance, tube reconnected to low intermittent suction. Patient denied abdominal discomfort, bowel sounds present in all quadrants. Patient tolerated procedure well. Please check out the attached link to watch a video of NG tube management. NG tube removal. An NG tube is removed once the patient no longer needs gastric decompression, suction, or tube feeding. Always verify the provider's order before removal. Removing it too soon can compromise patient care. Remember to follow the facility or agency policy and procedure. Start by checking the order. Then assess the suction canister or drainage bag. Note how much fluid is present, its color, and whether it's clear, green, or blood-tinged. This needs to be documented. Explain the procedure to reduce anxiety and gain cooperation. Position the patient upright about 30 degrees, which improves comfort and safety. After removal, give the patient mouth care. They often complain of a bad taste. Measure the drainage collected before disposal and record this on the intake and output sheet. Follow facility policy for disposing of the NG tube and container. Continue to monitor every 2 hours for abdominal discomfort, nausea, vomiting, or distension, and check bowel sounds to ensure the GI tract is recovering. Documentation is essential. Always include the time of removal and why it was discontinued. Record the drainage amount and description. Document how the patient tolerated the procedure. Did they cough, gag, or feel relief? This ensures continuity of care and communicates with the rest of the team. Please check out the attached link to watch a video of NG tube management. Tube feeding. Now let's review feeding tubes and pumps. Tube feeding can be delivered in different ways depending on the patient's condition and tolerance. Continuous feeding is given slowly over many hours, often by a pump, and is helpful for patients who cannot tolerate large volumes of formula at one time, such as those with limited gastric capacity or severe illness. Intermittent feeding is given in set amounts several times a day. This method can help patients who are reintroducing oral feeding or those who can tolerate larger boluses at scheduled times. The physician prescribes the exact amount of formula, which typically ranges from about 240 ml to 360 ml per feeding. There are also different types of tubes used for feeding. Plastic nasogastric tubes can serve multiple purposes: gastric lavage, tube feeding, or medication administration. Small bore silicone tubes are softer and narrower, designed specifically for tube feeding to increase patient comfort and reduce the risk of tissue damage. For long-term nutrition, patients may have a percutaneous endoscopic gastrostomy, PEG tube, or a jejunostomy tube, which allow for direct delivery of nutrients into the stomach or small intestine. These tubes are also used for medication administration. As nurses, it's important to know that feeding pumps are often necessary for patients requiring long-term nutritional support or those who cannot tolerate bolus feedings. Always verify tube placement before giving feedings or medications, monitor tolerance closely, and watch for complications like aspiration, clogging, or infection. Your role in monitoring both the method and type of tube is essential for patient safety and successful nutrition therapy. On this slide, you see 3 common types of tubes used for gastric decompression and feeding: the Levin tube, the weighted feeding tube, and the Salem sump tube. The Levin tube is a single lumen tube most commonly used for short-term decompression of the stomach or for the administration of medications or feedings. Because it is a simple tube with only one channel, there is a higher risk for suction-related trauma to the gastric mucosa, so it requires close monitoring. The weighted feeding tube is designed specifically for enteral nutrition. The weighted tip helps guide it past the stomach and into the small intestine, which lowers the risk of aspiration and allows for long-term feeding. This tube is usually used for patients who cannot safely swallow, but still have a functioning GI tract. The Salem sump tube is a double lumen tube with one channel for suction and the other acting as an air vent, which prevents the stomach lining from adhering to the tube during suction. This makes it safer for continuous suction and decompression. You'll most often see the Salem sump in patients with bowel obstructions, after surgery, or in critically ill patients who need their stomach decompressed. As LPNs, your role includes checking tube placement, ensuring patency, monitoring drainage or feeding tolerance, and preventing complications such as aspiration, infection, or skin breakdown around the insertion site. Understanding the purpose of each tube is critical so you can anticipate patient needs and provide safe care. Administering a tube feed. Before we begin a tube feeding procedure, it's important to gather all the necessary supplies to ensure a smooth and safe process. Preparation helps maintain infection control, supports patient comfort, and prevents interruptions during the feeding. First, we need the feeding formula, which provides the patient's required nutrition. Common brands include Gevity, Isosource, Boost, and Nutren. Each formula is designed for specific nutritional needs. Some are high in protein, fiber, or calories, while others are made for patients with specific conditions such as diabetes or renal disease. It's critical to verify that the correct formula and prescribed amount match the provider's order before administration. Next, the irrigating syringe, often a 30 to 60 milliliter syringe, is used to flush the feeding tube before and after the feeding. Flushing with sterile or tap water helps prevent the tube from clogging and ensures the full delivery of formula and medication. Remember that the water used should be sterile for immunocompromised patients, while tap water is usually acceptable for stable adult patients with intact immune systems. The syringe will also be used to administer the formula for bolus feeds by gravity. For continuous feeds by pump, a feeding pump and tubing are needed for continuous or controlled rate feedings. The feeding bag connects to the tubing and holds the prescribed formula. Even if a pump isn't used, as in gravity feeding, the bag is still necessary to contain and deliver the formula safely. A stethoscope is an important tool for verifying tube placement, especially in nasogastric feedings, by listening for air insufflation or assessing bowel sounds prior to feeding. This step helps confirm that the tube remains in the stomach and not displaced into the respiratory tract. Finally, gather gloves. Always wash your hands and apply gloves before handling feeding equipment or the patient's tube. Once all supplies are ready, verify the patient's identity, position them correctly in semi-Fowler's or Fowler's position, and proceed with the feeding following facility policy and provider orders. Before beginning any tube feeding, it's essential to perform a thorough assessment and proper preparation to ensure patient safety and promote tolerance of the feeding. Start by verifying the provider's order. This includes confirming the type of formula, the amount to be administered, and the prescribed rate. Double-checking these details prevents errors in nutrition delivery, which could lead to complications such as aspiration, diarrhea, or metabolic imbalance. LPNs should also ensure the order matches the patient's current condition and feeding route, whether through a nasogastric (NG) or percutaneous endoscopic gastrostomy (PEG) tube. Next, assess the abdomen for distension or tenderness. Abdominal distension, pain, or absent bowel sounds may indicate delayed gastric emptying, intestinal obstruction, or feeding intolerance. In those cases, feeding should be held and reported to the nurse in charge or the healthcare provider before proceeding. This step also allows the nurse to monitor for potential aspiration risk or other gastrointestinal complications. During preparation, position the patient by elevating the head of the bed, HAOB, to 30-45 degrees. This semi-Fowler's position is one of the most important safety measures. It prevents aspiration of formula into the lungs and promotes proper digestion and gastric emptying. Maintain this position throughout the feeding and for at least 30-60 minutes afterward. Next, perform hand hygiene carefully before handling any supplies or the feeding tube to prevent introducing infection into the patient's gastrointestinal tract. Then apply gloves as part of your personal protective equipment, PPE, to maintain aseptic technique and protect both the patient and yourself from contamination. These preparation steps create the foundation for a safe and effective tube feeding procedure. Skipping or rushing through this process can lead to serious complications, so take time to ensure each step is completed correctly before starting the feeding. Start by pinching off the tube and removing the plug, cap, or clamp. Pinching the tube before disconnecting or opening it prevents leakage of formula or gastric contents, which helps maintain cleanliness and prevents contamination of both the patient and the environment. Main technique here is part of good infection control practice. Next, it's crucial to check tube placement before every feeding or medication administration. Many hospitals require the NG placement be confirmed by X-ray when initially placed. For a nasogastric or NG tube, attach a syringe and gently aspirate 5 to 10 milliliters of stomach contents. Observe the color and consistency. Gastric aspirate usually appears cloudy, off-white, or greenish, and measure the pH, which should typically be 5.5 or below if the tube is in the stomach. This confirms the tube's correct placement and reduces the risk of aspiration. For small bore feeding tubes, such as Dobhoff or Corpac, placement verification is done initially by X-ray. After that, the nurse confirms ongoing placement by checking the external tube length and markings before each feeding. Remember, never rely on air insufflation or whoosh tests, as these methods are outdated and unsafe. After placement is confirmed, check for residual volume to assess gastric emptying and feeding tolerance. Using a syringe, withdraw stomach contents and measure the volume. A residual volume greater than 500 milliliters is often considered high and should be reported to the provider. However, always follow the provider's order and facility policy, as the threshold may vary. If the residual is high, the feeding may need to be held temporarily to prevent regurgitation and aspiration. Remember that aspirating fluid is not expected from jejunal tubes because the jejunum doesn't retain contents like the stomach does. This is a key point. Don't assume a lack of residual means the tube isn't functioning if it's a jejunal feed. Finally, reinstall the aspirated fluid back into the stomach unless your facility policy or the provider instructs otherwise. This helps prevent loss of electrolytes and gastric acid, maintaining fluid balance and pH stability. Always document the amount of residual and your nursing actions clearly after this step.